All right. So welcome to the exam review for exam 1. The main topics for this exam are going to be communication, autonomy, and safety. So that's what you really want to focus on for this exam. My name is Sabrina. I'm going to be one of your tutors this semester. Your other tutors are Ella, Maya, and Micah. We'll each be doing a review for one of the exams. If you haven't already, please make sure you are registered on NAC for this meeting. It just shows the school that there is a demand for tutors and that they should continue using NAC. All right, so some tips for success are to take notes in class, use the textbook and ATI to supplement the information you've learned in class. Make sure you're doing practice questions as you learn the content, and make sure you engage in class. If you have any questions, just type them in the chat or just unmute yourself and call them out. All right, so to start with mental health and mental illness, mental health is a state of well-being in which individuals reach their own potential, cope with normal stressors of life, work productively, and contribute to society. Whereas mental illness is any psychiatric disorder with a definable diagnosis. Disorders are manifested in significant dysfunctions that may be related to developmental, biological, or physiological disturbances. So mental illness is anything that interferes with their daily functioning and their daily life. And mental illness is culturally defined. In some cultures, having hallucinations or delusions is seen as a gift, not as seen as a sign of mental illness. So it's important to understand their culture and ask questions. So mental illness, some signs and symptoms of mental illness are appetite changes, sleep changes, labile mood, low mood. I have not sent out this PowerPoint yet. I will send it out after the meeting to anyone that's registered on NAC. If you had trouble registering on NAC or anything like that, send me a message on GroupMe and I will send it out to you as well. Okay. So sleep changes, labile mood, low mood, hallucinations, delusions, negative coping, emotional outbursts. And psychosis is a loss of touch with reality. Does anyone know the difference between hallucinations and delusions? Feel free to put it in the chat or just unmute yourselves.
Delusions, isn't that where you're hearing things, and hallucinations is where you're seeing things?
Kind of. So hallucinations involve the senses, so auditory, tactile, visual, etc., taste. It's something that is not there, whereas delusions is involving false beliefs, such as someone is out to get them. And then a labile mood is rapid or extreme mood swings. All right, so the DSM-5 is the official guideline for diagnosing psychiatric disorders. It does not treat mental disorders, just diagnoses. And then remember that the patient is a person, not their diagnosis. So you want to say he has schizophrenia, not that schizophrenic patient, or he is a schizophrenic. Psychiatric mental health nursing. So as a psychiatric mental health nurse, you work with people throughout the lifespan. You promote mental health through assessment, diagnosis, treatment of behavioral and mood disorders. It's used in a variety of settings with a variety of populations, such as the homeless or anyone involved in a crisis. And then there's two different levels. Basic level is like an RN. They deal with admission and care, whereas advanced practice does the psychotherapy. So interpersonal theory is short term. All needs are met through interpersonal relationships to improve mental state and to decrease stress. And it's most effective in treating grief and loss, interpersonal social disputes, role transitions such as becoming a mother or any sort of change that they may be struggling with. Psychodynamic theory is to recognize unconscious thoughts to make better choices. So you want the patient to realize what they're thinking that they may not have been before. Classical psychoanalysis is outdated. I don't think you really need to worry about that one that much. It's not really used anymore. And the newer psychoanalysis, this focuses on the here and now. The best candidates are the worried well, and it is not used for those with severe mental illness. Worried well is just people who are in good health that believe otherwise. Developmental theories, this helps determine what type of interventions will be most effective. And then these are just the two most common developmental theories. Behavioral therapy, the goal of behavioral therapy is just to modify and replace negative behaviors. And then that can be done through modeling, operant conditioning, exposure therapy, aversion therapy, or biofeedback. Make sure you know those. Modeling is where you act as a role model for your patient. Operant conditioning is positive reinforcement. So you give them a reward for changing one of their behaviors in a more positive manner. Exposure therapy is used for phobias, anxiety, and fears, where they're encouraged to face their fears. So if they're scared of leaving their house, they're encouraged to go for a walk or do something that maybe isn't necessarily around people at first, and then gradually increase that exposure. Flooding is an extreme version of exposure therapy where they're exposed to a large amount of stimulus all at once. Aversion therapy is aversion therapy targets negative behavior with a negative stimulus. So there's medications that you can give people that suffer with alcohol use disorder, and it'll make them sick if they drink alcohol. That would be an example of aversion therapy. Biofeedback is just, it teaches them relaxation and breathing whenever they experience a stressor. So cognitive therapy, there's different types. So this is just states that thoughts come before feelings and actions. Trauma-focused cognitive behavioral therapy is most common with sexual abuse trauma in children. However, it's been expanded for all ages, and it identifies feelings and how to manage them. Dialectical behavioral therapy helps patients identify negative thoughts and patterns, and it's used with personality disorders, specifically borderline personality disorder. Cognitive behavioral therapy is utilized for various psychiatric conditions. Patients identify their negative thoughts and turn them into more rational, positive thoughts. So the goal is to challenge their negative automatic thoughts. All right, in the biological model, this assumes that abnormal behavior is a result of a physical problem, not necessarily a mental problem. So this can be chemical imbalances, genetics, neurobiological issues. So treatment is going to target the problem site. So pharmacotherapies, medications, and then brain stimulation therapies, electroconvulsive therapy, vagal nerve stimulation, and deep brain stimulation. So going from least invasive to most invasive on the continuum of psychiatric care, you have outpatient care, which is community mental health centers, ACT, outpatient psychiatrists, and then inpatient care, crisis stabilization units, psychiatric hospitals, and then the most invasive is going to be your state psychiatric facilities. So for community-based care, there's assertive community treatment, ACT. So this is used with patients whose mental health disorders make it hard for them to seek treatment themselves. They may have a history of repeat hospitalizations or ER visits, and this brings the treatment to the patient. Partial hospitalization programs, this is a mixture of inpatient and outpatient care. So it's typically Monday through Friday, about 6 hours a day. Intensive outpatient program is a few times a week, typically like 3 hours a day. So this is also most invasive to least invasive. And then telepsychiatry, this is more affordable and accessible to to a lot of populations. However, it may not be effective for all conditions. So it's important to determine whether this would be effective for your patient based on their schedule and how severe, how much treatment they need. So this is just treatment and prescriptions through video chat. So the role of the nurse in the outpatient setting, you're going to need good communication. You're going to need to have good problem-solving skills, promote autonomy, which is the patient's right to make decisions themselves, and then remain non-judgmental. So the role of the nurse in the inpatient setting, safety is number one. You want to ensure safety at all times for yourself, the other staff members, the patients. You want to be well-versed in crisis de-escalation, maintain a safe therapeutic environment, observe the patient's mood and behaviors, data collection, care plans, treatment team communication and coordination. And then the L stance, I don't know if you guys were told about the L stance, but that's essentially you don't stand directly in front of the patient, you stand off to the side a little bit at a safe distance, just so it doesn't feel like you're crowding them. And it also makes sure you remain safe in the event that anything happens. And the knowledge of patient rights. So patient rights, patients have the right to apply to patient rights apply to involuntary and voluntary admissions. Patient rights are upheld even after death. So patients have the right to refuse treatment, patients have the right to leave AMA, patients have the right to informed consent, confidentiality, to be treated with dignity, be present when their belongings are searched, and to keep their belongings unless they're deemed dangerous. So, and there's a few more on there, but those are kind of the main ones. The right to not be restrained. The only one that is different for involuntary admissions is the right to leave AMA. They cannot leave AMA without a court order. So primary prevention, this is before the problem emerges. So this is education. So think primary, prevent. Secondary prevention, you want to catch it early. So secondary, screening. Tertiary, you want to get them back to baseline. So this is going to be rehab. So tertiary is treatment. So the major goals of family therapy are to improve the skills of the individual members as well as strengthen the unit as a whole. And they do this through cohesiveness, communication, appreciation, commitment, coping strategies, collective beliefs and values. The identified patient is seen as the problem, so the family member whose beliefs, perceptions, actions, and responses demand an immediate fix. And then triangulation is where one family member will not speak to another family member, therefore they only communicate through a third member. So psychiatric mental health, advanced practice registered nurse goals. So this is going to be to reduce or eliminate both individual and familial dysfunctional behavior, reduce, resolve family conflict, problem solving, help family members meet their individual needs, and then strengthen the family's coping mechanisms as a whole. Culturally relevant care. So deviance from cultural expectations can be considered an illness by other members of the community. And then no ethnocentrism, cultural imposition. Ethnocentrism is the idea that your religion is the only right or correct one. And then cultural imposition is forcing your religion onto others. We want to promote and encourage helpful practices, accommodate and negotiate neutral practices, and repattern and reconstruct harmful practices. Communication barriers. So these please do not allow family members or friends to translate, because things can get kind of misconstrued through that if the family member or friend doesn't completely understand what you were trying to say. So always use an interpreter. There's stigma surrounding mental health. People with mental health problems are often seen as weak or dangerous by society. So, and this can often prevent people from seeking help because they're afraid of being discriminated against. And then there's misdiagnosis. And a huge part of the misdiagnosis is culture-bound syndromes, which is where signs and symptoms are recognized as a mental illness in one culture, but seen as a gift in another culture, such as like hallucinations. So you want to make sure you're culturally sensitive in your assessments. Never make assumptions on any sort of culture, whether you think you know about it or not. You want to make sure you ask questions because people are different, and no matter what culture they're a part of, they might interpret certain beliefs differently. So you just want to make sure you ask. You want to be culturally aware, do not stereotype. Acknowledge potential barriers, check yourself at the door. So make sure any biases you have, you do not display those onto the patient, and then remain non-judgmental. Bioethic principles. So there's autonomy, which is the right to make decisions about one's own body. Does anyone know an example of autonomy?
Like they have the right to decline medication or some type of treatment.
Yes, very good. So refusing a treatment, refusing a medication, or choosing one treatment option over another. Those are all examples. What about beneficence? Does anyone know an example of beneficence?
Maybe staying along with a patient who may be in distress or crying.
Yeah, so it's doing good despite the nurse's personal beliefs. So doing what's in the patient's best interest, such as being there to support them, or providing comfort to a patient at end of life, or assisting another staff member with a task that cannot be performed independently for the patient's safety. Those are all examples of beneficence. Very good. What about non-maleficence?
Like not putting a patient in restraints just out of convenience. Like you're not trying to harm the patient.
Yeah, very good. Another example would be holding a medication due to adverse side effects, or it's just not in the parameters to give the medication. Um, Justice is being non-judgmental and impartial to a patient and provide care. So an example of this would be to provide care, no matter their race, gender, sexual orientation, etc. Fidelity is doing no wrong. So an example of this would be coming back to check on your patient when you say you will, or if it's the first time your patient is receiving a medication, you come back and check on them consistently, or have another staff member check on them just to make sure they're not having any adverse effects. Veracity, this is telling the truth even when a lie may be more desirable. So being honest about the side effects of medications they are taking, or being honest with them about the risks associated with certain treatment options. You just want to make sure you're always honest with them, even if you don't think it's what they want to hear. So the legal process for admission, voluntary admissions is where the treatment is requested by the patient or the guardian directly. They have the right to get treatment and leave. However, they may need to be evaluated before their release. Involuntary admission, the patient is admitted without consent. Reasons for involuntary admission are mentally ill, danger to self or others, gravely disabled, illness prevents voluntarily seeking help. These patients cannot leave AMA without a judge order. So writ of habeas corpus is it just challenges unlawful detention. So if a patient feels that they are being detained without reason, they can challenge their involuntary admission. And then the least restrictive alternative doctrine states that we should take the least restrictive or drastic measures first. So don't automatically jump to restraining a patient when they start acting out or becoming agitated. Involuntary admission, So it's typically about 24 to 96-hour observation period, and there's always a court hearing before discharge. There's two different types of involuntary admission: the Baker Act, which is for mental health care, where the patient is a risk to themselves or others, and then the Marchman Act, which is substance abuse care, where the patient is also a risk to themselves or others. So the legal process for discharge, make sure you know these. So unconditional release is the termination of legal patient institution relationship. It's just the end of treatment. There's no strings attached. It's just the end of treatment. Release against medical advice. So the patient can leave after signing papers stating that they understand they are leaving AMA. Provide patient education. However, you cannot force them to stay. Conditional release is required outpatient treatment for a time with follow-through evaluation. So for them to be released, they have to agree to outpatient treatment. Assisted outpatient treatment is court-ordered outpatient treatment. So that's the only difference between those two. Assisted is court-ordered, whereas conditional release, they just have to agree to it. Patient rights. So again, the right to refuse treatment. Right, I put that on there twice, my bad. Right to treatment, right to refuse treatment, and then right to informed consent. So make sure that they know the risks, benefits, alternative treatment options, but so that way they can make an informed decision. And they can withdraw their consent at any time, even if it's right before the procedure. So confidentiality in psychiatric mental health care, you cannot release any information to anyone, including family and friends, without the patient's consent. You do not want to discuss this patient's medical information with other healthcare professionals that are not assigned to the patient, and they have the right to confidentiality still applies even in the event of death. So when you can break patient confidentiality is the duty to warn third parties. So nurses are obligated to report when a patient threatens another person or is a danger to the public. And then we are also mandatory reporters of child and elder abuse. So if they admit to abusing their child or a parent, then it's mandatory to report that. So a tort is any wrongful act that results in injury of another person. There's intentional and unintentional. Intentional is willful acts that violate another person's rights or property. So this can be assault, battery, false imprisonment, invasion of privacy, defamation of character. Unintentional is unintended acts that produce harm or injury. So negligence or malpractice. So standards of nursing care, so Nurse Practice Acts, it's state specific. Professional associations, so you have the ANA, which is the American Nurses Association, which fosters high standards of practice, and then the APNA, which is American Psychiatric Nurses Association. They advance the science and education of psychiatric mental health. Institutional policies and procedures define criteria for care, can be used in legal proceedings to prove if the nurse met or failed to meet these standards. If the institution is substandard, the criteria of quality of care may also be substandard. Customary practice. So custom practice is the traditional behavior that is followed by a culture. Can be used as evidence of standards of care. Customary use of restraint in emergency situations, violent, risk of harm to self or others, confused. Standard customs do not protect you in the event of a patient charging that their rights were violated. So forensic nursing. Forensic nursing focuses on the patient populations affected by violence and trauma. Forensic psychiatric nursing focuses on assessment, evaluation, and treatment of victims or perpetrators. And then correctional nursing is the care of anyone involved in the criminal justice system, such as those that are in prisons or jails. So general roles of forensic nurses are to provide expert testimony, collect and preserve evidence. Specific roles are psychotherapists, forensic nurse examiners, competency evaluators, and criminal profilers. The nursing process, you have assessment, diagnosis, outcomes, identification, planning, implementation, evaluation, and then documentation is kind of the unofficial part of the nursing process. So for assessment of children, you want to observe them for signs and symptoms of pain and consult the caregivers. Caregivers will often be your primary source of information for children. So the caregivers will often describe behavioral concerns. And then you want to consider regression, which is essentially when their development starts moving backwards. So bedwetting or sucking their thumb. Adolescents, they often have a concern of confidentiality. So you do want to tell them that you want to be honest with them that what they say may need to be disclosed. However, they do still have a right to some privacy. Older adults, you want to rule out physical signs and symptoms, avoid stereotypes, avoid baby talk, so don't call them honey or sweetie. And then you want to sit close to them and use a lower pitch of voice. They have a harder time hearing and understanding a higher pitch of voice sometimes. So, yeah. Okay, so planning actions, you want to make sure any of your planning is safe, compatible, appropriate, realistic, individualized, and evidence-based. You don't want to make a goal for the patient and be like, they'll be completely cured by the time of discharge, because that's not realistic. You want them to be stable and have their mental health under control, like not be actively hallucinating and stuff like that, and understand their medicine regimen, but you want to be realistic with any goals you set for them. So distress is bad stress. This often leads to decreased functioning, whereas eustress is good stress. It leads to increased functioning, and it's often what causes people to become motivated. So short-term consequences of stress, the fight or flight response, which is increased blood pressure, heart rate, respiratory rate, and cardiac output. Does anyone know some other signs and symptoms of stress? Okay, some other signs and symptoms are reduced immune function, loss of appetite, poor sleep, and then the general adaptation syndrome. This has 3 phases, so alarm, acute stress phase, resistance adaptation phase, and then exhaustion phase. So the alarm phase is going to be your initial fight or flight response. Resistance is going to be the optimal resistance to the stressor. And then exhaustion phase occurs when attempts to resist the stressor fail and your resources become depleted. Long-term consequences of stress are anxiety disorders, diabetes mellitus, fatigue, cardiovascular diseases, increased risk for infection or illness, and depression. All right. So responses to stress, we have perception. It's how we view the stressor, and how we view the stressor affects how we experience that stress. Individual temperament is genetic disposition, coping, experiences. Social support acts as a buffer against distress, and it enhances mental and physical health. Support groups allow people to find support within the community. Examples of this are Alcoholics Anonymous or Narcotics Anonymous. Culture, different cultures view stress differently. So you want to make sure you ask questions and see how they view it. Spirituality and religion aids in relaxation, feelings of belonging and support, and help people cope with stressors. So the therapeutic nurse-patient relationship is surrounded with dignity, respect, The needs of the patient are explored, patient and family participation in their plans of care, and clear and appropriate boundaries are established from the beginning. Boundaries are the expected and accepted legal, ethical, and professional standards that separate the patient from the nurse. Over-involvement increases the risk for boundary crossings, boundary violations, professional sexual misconduct, and blurring roles. Under-involvement creates a lack of trust within the relationship. Neither over-involvement nor under-involvement are good. So you want to kind of have that, meet that area in the middle. Definitely make sure you know these two, transference and countertransference. Transference is when the patient displaces feelings onto the nurse. So if the patient says, "You remind me of my mother," or something like that. Countertransference is when the nurse displaces feelings onto the patient. So if that patient reminds them of someone that they went to high school with that they didn't necessarily get along with, and they reflect that feeling onto the care of the patient. Kaplo's 4 phases. Pre-orientation phase, you want to build rapport, get to know the patient. Orientation phase, you're establishing boundaries and getting to know the patient a little bit more. Working phase, this is where you establish goals, develop coping mechanisms, encourage the patient to change their behaviors. And this is the longest phase. This is where most of the treatment is done. And then termination phase is the end of the nurse-patient relationship. So this is with individuals, not groups. Techniques that enhance communication are empathy, non-judgment. You want to be non-judgmental, active listening. So make sure you're listening to nonverbal communication as well as verbal, and you want to make sure you listen more than you talk. You want to make sure you offer yourself. So sit with them in silence to prove that you're there when they want to talk, and if they don't want to talk, just you're there to provide support. Clarifying techniques, make sure you know these. Paraphrasing, it just restates the patient's basic message back to them in different words. Restating, this repeats the patient's same keywords. Reflecting, you question or simple statement that conveys the nurse's observations of the patient when discussing sensitive topics. And then exploring, so you prompt them to tell you more. So tell me more, how do you feel about this? Stuff like that. And then you want to make sure you ask questions, but don't ask too many questions. Don't make it feel like you are interrogating them, but you do want to show them that you're interested in listening. Barriers to communication, don't ask why questions. This makes them feel like you're minimizing their feelings. Excessive questioning makes them feel like they're being interrogated, and you don't want to give advice or express approval or disapproval. Phases of group development. So you have the planning phase where you figure out the logistics and you prepare for the group. Orientation phase is where the introductions are done. Working phase is problem solving. And then termination phase is where the group ends, termination of treatment. And then evaluation and follow-up just determines whether the group was effective, whether the individuals met their needs. So, and then you can just kind of fix whatever needs to be fixed there and then start again. So roles of the group members, you have the task roles, which helps keep the group focused, the maintenance roles, which helps maintain cohesion among the group and relieves tension, and then individual roles, did the individual meet their needs? The leadership styles, you have the autocratic leader, they're controlling and do not encourage much group interaction. The democratic leader, which supports extensive group interaction in the process of problem solving. This is the desired leadership style. And then the laissez-faire leader, which is passive and allows the group members to act any way they want and does not exert control. So the different types of members, you have the monopolizing member. They do all the talking. They essentially take over the group. Some interventions on how to deal with the monopolizing member are to encourage others to join in and remind the group that everyone deserves an equal chance to participate. If they continue to do all the talking and interrupt, then you want to speak with them in privately. So the disruptive member, they interrupt other members and are just very disruptive. Interventions for this would be to listen objectively, discuss cause of anger in private, and emphasize matter-of-factly. The silent member does not participate. Some interventions would be to determine the cause of their silence and require response. However, when you require a response, provide extra time for the group member to gather their thoughts and then come back to them. All right. So now we're going to get on to some practice questions. Just throw your answer in the chat or call it out, whichever you're most comfortable with. The first question is, a nurse on an inpatient mental health unit is attending an interdisciplinary treatment team meeting with a client who has bipolar disorder with rapid cycling. The client is being prepared for discharge following his 4th admission in the last year. Which of the following referrals should the nurse make for the client first? A, assertive community treatment, B, supportive groups, C, private counseling, D, vocational rehabilitation services. Yeah, so this one's A, assertive community treatment. So the keywords in this problem are his 4th admission in the last year. So with patients that receive ACT, it's used with patients who have severe mental illness, and their illnesses don't typically allow them to seek treatment themselves. And you may also see repeated hospitalizations with these types of patients. All right, great job. So the next question is, a nurse is teaching a patient who has admitted to verbally abusing his children about stress management techniques. Which of the following strategies is the nurse providing? A, tertiary prevention, B, individual psychotherapy, C, family psychotherapy, or D, primary prevention? All right, so this one is kind of hard. It is tertiary prevention because he's already admitted to verbally abusing his children. So this is getting him back to baseline of not doing that. I know it says teaching and you think of education with primary. However, because this action has already occurred, it would be tertiary. Does everyone understand that? Does that make sense? Okay. All right, so the next question is, a nurse is administering an oral sedative to a client who is receiving care following an involuntary admission. The client states, I am not taking any more medication. Which of the following actions should the nurse perform? A, administer the medication by another route. B, refer the client's refusal to the facility's ethics committee. C, inform the client that due to her involuntary admission, she cannot refuse sedative. D, document the client's refusal of the medication in the EMR. Very good. You all got that very fast. Yes, it's D. And then you can read that if you want. All right. A nurse is caring for a client who is post-operative following an amputation of the lower left leg. The client states, "I can't believe this happened to me. I don't deserve this." Which of the following responses should the nurse provide? A, tell me what you're feeling about what has happened. B, the feelings you're having are normal following an amputation. C, I agree with you. You did not deserve this. D, what makes you say that you don't? Very good. You all got this one very quickly. Yes, it is A. So you just want to prompt him to talk for more about why he's feeling that way. A nurse on a mental health unit is caring for a client who begins throwing objects at other clients. Which of the following actions is the priority nursing intervention? That was supposed to say intervention. A, attempt to restrain the client's arms. B, administer an anti-anxiety medication. C, place the client in seclusion. D, tell the client to stop the behavior. Yes, it is D. You always want to start with the least invasive. So first would be just confronting the patient about their behavior, and then you'd move on to the chemical restraints, seclusion, and the physical restraints. A nurse is talking with a client about his admission to a mental health unit. The client states, "I just don't know if I should be here. What will my family think?" Which of the following responses by the nurse uses the therapeutic communication technique of reflection? A, it sounds like you're concerned about your family's reaction. B, what your family thinks isn't important. You need to be concerned about getting well. C, it sounds like your family doesn't seem to understand you. D, many clients are concerned about the reaction of their families. All right. This one is A, because with reflection, you're just directing their statement back to them. All right. And this just allows them to think about their statement more and organize their feelings. A nurse is caring for a client who spent the past several minutes mumbling about being doomed to die and is now pacing in an increasingly agitated and angry manner. Which of the following actions should the nurse take first? A, administer PRN medication for agitation. B, attempt to reduce environmental stimuli. C, request a prescription for physical restraints. Or D, place the client in seclusion. Very good. It is B. Again, always the least restrictive options first. All right. A nurse is leading a support group for clients who are about to be discharged from an acute care mental health facility. During a group session, a client states, "I'm scared of being discharged." Which of the following responses should the nurse offer? A, maybe you're not ready to be discharged yet. B, do others in the group have similar feelings they would like to share? C, you ought to be happy you are being discharged. D, how many in the group feel this member is not yet ready to be discharged? All right. Yes, the answer is B. Remember with group settings, they can receive support from other members of the community, as well as understand they are not alone in certain feelings. So this just allows them to seek support. All right. A nurse is obtaining a client's medical history prior to scheduling the client for electroconvulsive therapy. Which of the following findings should the nurse identify as a potential complication of the procedure? A, severe depression, B, cardiac arrhythmia, C, bipolar disorder, D, Parkinson's. All right. Yes, the answer is B. A client who has a cardiac arrhythmia needs further evaluation since the greatest risk of death due to electroconvulsive therapy is related to cardiac complications. A nurse is assessing a newly admitted client who has schizophrenia. The client suddenly looks at an empty chair and appears to be listening to something. Which of the following responses should the nurse make? A, I thought I heard something too. B, is someone telling you something? C, what are you hearing? D, there is nobody in that chair for you to listen to. All right. Yeah, the answer is C. So this open-ended question allows the nurse to figure out what the client is hearing without validating or disagreeing with the hallucination. You want to make sure that they are not hearing anything that makes them dangerous to themselves or others. You just want to know what they're hearing or seeing. All right, so now we have some dosage calculation practice questions. These are kind of the most common conversions that you should know. So if you need to, take a picture of it. There's other conversions. However, these are the most common ones. All right. So the first question is the doctor writes an order for an oral liquid medication. The order says that to administer 20 grams by mouth, BID. Pharmacy dispenses you with 10 grams per 15 milliliters. How many milliliters will you administer per dose? All right. So the answer is 30 milliliters per dose. And then you can see the work right here. I'll leave it up for a minute for anyone that needs to look at it. Yes, but it was asking per dose. So it's 20 grams by mouth twice a day. Pharmacy dispenses 10 grams for every 15 milliliters. So it's just asking for dose.
Yeah, but if you're giving it twice a day, that means you would only give 15 per dose, and that would be the 30 milligrams per day, right? Or no?
Right. It doesn't say that it's divided equally twice a day. This is just 20 grams administered twice a day. Yeah. Okay. The doctor writes an order for an IV bolus. The order says to administer 20 milligrams IV BID. You're supplied with a vial that is labeled 40 milligrams per milliliter. How many milliliters will the patient receive daily? All right, so the answer for this one is B, 1 milliliter per day. Because remember, it's not asking per dose this time, it's asking per day. Does everyone understand this one? Okay. The doctor orders an IV weight-based medication to be infused at 12 milligrams per kilogram. The patient weighs 115 pounds. You are supplied with a bag of IV medication that reads 100 milligrams per 2 milliliters. How many milliliters per hour will you administer? All right, so the answer for this one is C, 12.5 milliliters per hour. Does anyone have any questions on this? All right. That was the last question. So does anyone have any questions about any of the content? All right. Of course. Have a nice night, guys.